We now ask Tim Spalding to give a talk on allografts. Thanks.
Okay, so this is all again adding into our spectrum of treatment of options available. So this is osteochondral allografts. What they are, where we are today with those techniques, and then what we can expect from that, and why some people have called this their go-to operation, especially with the combination treatments of meniscal transplant and the worn knee. So what it is, it's like a mega oats, as Arthrex will call their instrument system. It's a large coring plug device. So you will take a larger area, 20 millimeters, 25 millimeters from the condyle, prepare that base as a kind of a shell allograft. So top right picture there, coring out that area to make a crater. Then on the bottom line, the hemicondyle, and take a core from that condyle, cut it to the right depth, and then a press fit into the knee. So this is large osteochondral shell allografts rather than small plugs. It's whole tissue, so it puts in a whole new surface. It's everything there, and as Bill Bugbee has called this, it's seed versus sod. So rather than having the seed of an ACI, you put the whole thing, the whole turf back in there. It can be shaped, then it's curved to fit, it's already there, it's from a knee, it's a neuroavascular, so it's ideal tissue for transplanting. It's been around a long time, this option, popularized with Alan Gross in Canada, small fragmented grafts initially, and then through this process of very thin shell allografts, dowel allografts, and really since 2002 or so it's been more available, distributed as an option, large, getting in a whole half a condyle. One of the leading names who's done most research on this, Bill Bugbee in California, and his research then has gone through looking at the how allografts work, the technique, and where it fits in that treatment. And initially you had to implant within 14 days because this is fresh tissue. That's an important point. It's not frozen. That really has a low success rate. And now there's better extended storage, and it's 28 days to put it in. This is the kind of timeline from harvest through the processing and then cultures, and then offering the graft out. So you have a list of surgeons who are waiting for a graft of that size of femur, and then it's released day 15 or so, and you've then got until day 28 to put it in. So there's a narrow time window, so this is fresh graft surgery. There are many papers out there now on clinical outcomes, and a whole load of the aspects have been looked at and studied. So there's quite a mass of data over the years has been produced. I'm just going to focus on some of those specific results. Bill Bugbee presented on his clinical database of a huge number of patients, over 1,000 patients over his time, and has tried to look at those factors, and many of those publications are from his unit. There's a particular selected group he presented on at the recent ICRS meeting of 200 cases with a minimum 2-year follow-up. Age there you can see is 31, mostly male, mainly osteochondritis dissecans type lesions, osteochondral defects, therefore loss of the bone as well as the joint surface, but 23% being degenerative chondral lesions. Mean size there, 6 square centimeters, and the thickness then 6 millimeters deep. So that's articular surface and the bone. So it's a small amount of bone on the bottom of the articular surface. So reoperations 26%, but if you look at the types of failure, then on the right-hand side there, allograft failure at 8%, but the operations not related to the allografts is a higher number. So actually the number of failures is quite low at 8%. Survivorship, we've got this figure at 10 years, 87% at 10 years of the survivorship on this group. 89% satisfied. So this is quite an in-depth analysis of all his patients. But the summary of that data in our time here is then, so he's got 6-year mean follow-up, 6 centimeter graft size, and a 6 millimeter graft thickness. And this is then what you can quote as the failure. 8% failure, 26% total number of reoperations, but not all for failure of the graft. 75% getting back to sport, and a 90% 10-year survivorship to be expected from this technique now when it's gone through all its iterations, and 90% satisfied patients for the large lesions. Other important point to note, the lateral condyle can be used for the medial side. And that's opened up a whole new increase the supply of grafts, because mostly it's medial needing repair, and if you've got a lateral femoral condyle as well to be used, then that increases the availability of grafts. And the radius of curvature is not too far out to be able to be used, and the studies showing that, so it can be used, and that's helped. So in conclusion, this is for single defects. The technique is so much better now. The instruments are being improved all the time, and the method, therefore, to doing it to ensure you get a good perpendicular access is there. There's minimal bone. You have to spray wash it to remove any of the host cells. It's technically easier to perform, and there's thinner bone reduces this bioburden for the creeping substitution. And the long-term results now seem to be very supportive of this technique for certain types of lesions. But it is expensive. It's in pounds, it's £13,000 for a half a condyle coming from the States. Our UK tissue bank won't do these grafts, so it's very expensive. But as an option, that's the data that goes with it. Thank you.